Hello everyone, I'm Amna Naveed, one of the internal medicine residents at Beaumont Hospital, Dearborn. I'm honored to present a very interesting case of methotrexate withdrawal and complete remission of high-grade B-cell lymphoma in a rheumatoid arthritis patients, leaving ours and many minds puzzled in literature. As we all know that rheumatoid arthritis patients have a twofold increased risk of developing lymphoproliferative disorder. However, methotrexate associated lymphomas in rheumatoid arthritis patients were first time brought to attention in early 1990s. The role of Epstein-Barr virus as a proposed mechanism is being heavily emphasized to justify the lymphoproliferation as a result of methotrexate therapy. Methotrexate withdrawal in our case led to complete remission, a causation dilemma yet to be solved, questioning the first line treatment for rheumatoid arthritis. Here we have a case of a 71-year-old gentleman with past medical history significant for rheumatoid arthritis, presenting with recurrent right sided neck swelling and tenderness with waxing and waning lymphadenopathy for the past few months. Physical exam revealed bilateral cervical and supraclavicular lymphadenopathy that was firm, mobile, and non tender. Laboratory findings revealed an elevated LDH level of 365 units per liter. CT of the neck with IV contrast showed enlarged cervical lymph node chain with findings concerning for metastatic adenopathy. CT chest, abdomen, and pelvis showed mediastinal, hilar, inguinal, and retroperitoneal lymphadenopathy with widespread. Based on PET-CT finding, dual score for lymphoma staging was 4, with immunohistochemistry showing B-cell lineage and high proliferative index, as shown on Ki67 stain in our poster. Lymph node biopsy showed diffuse large B-cell lymphoma. Fluorescent in situ hybridization was positive for Epstein-Barr virus. The final diagnosis was iatrogenic Epstein-Barr virus positive lymphoproliferative disorder, methotrexate associated polymorphic type, that is compared to post-transplant lymphomas because of the similar phenomena of immunosuppression as caused by methotrexate. Methotrexate therapy was withdrawn from our patient, and the patient showed regression and complete remission in the following physical exams and subsequent imaging studies. As shown in our poster, how lymphadenopathy is decreasing in size and number, leading to complete resolution after 29 weeks from the day of diagnosis. Our patient is still in remission and going strong. What I want to highlight from this is that how this perplexing solution has led to complete remission without requiring chemotherapy for high-grade B-cell lymphoma. In US, B-cell lymphoma comprises around 85%, of which diffuse large B-cell lymphoma has the highest incidence. 50 cases of regression of non-Hodgkin lymphoma have been reported in literature after methotrexate withdrawal. The most important thing is that, despite not knowing the exact mechanism, the response of complete remission has actually led to studies to see how much duration of watchful waiting is actually required to see response, regression, and remission, which by itself is an amazing phenomena to see in the world of medicine. Let's look at the right lower part of our poster showing a graph, time to complete remission after methotrexate withdrawal. Here, after 2 weeks, there are 3 patients showing partial remission and only 1 patient showing complete remission. After 4 weeks, the number of patients showing partial remission increased and showing complete remission was 2. After greater than 8 weeks, there were 9 out of 10 patients actually showing remission, which highlights the importance of actually waiting to see the response and not going to chemotherapy immediately. This is further depicted in the biopsy of an oral lesion of one of the patients on methotrexate therapy in the lower part of our poster, which showed regression of CD positive large cells after withdrawal of therapy within 2 weeks. That's amazing. If we look into how immunosuppression and autoimmunity actually lead to lymphoproliferation, we'll see its why opposing pathways, which itself is perplexing. So, is the methotrexate the culprit? Does remission actually means causation? There is a proposed mechanism of how latent Epstein-Barr virus is activated by methotrexate due to immunosuppression, and how EBV-infected B cells have the propensity to proliferate. And at the same time, there is decreased surveillance by the T cells infected with Epstein-Barr virus. This is further supported by the fact that incidence of non-Hodgkin lymphoma associated with Epstein-Barr virus in rheumatoid arthritis patients not exposed to methotrexate was low, around 2%. So, methotrexate has a role to play. taking this into consideration, this puts the first line treatment for rheumatoid arthritis in dispute, posing a big challenge to rheumatologists. So I end here with a question. Will we be able to take methotrexate therapy for ourselves with the fact in mind that simple methotrexate withdrawal will lead to remission in case of a lymphoma development? Thank you for listening.